Hi, my name is James Hopper. This is the fourth of four videos, and today we're going to do a nasogastric tube. Um, the first thing we'll do is we're going to check our empty orders to make sure, okay, we're going to give an NG tube to the correct patient. We're going to go ahead and assess why the patient needs an NG tube, and we're going to go ahead and come to the patient's room and verify that we have the correct patient. So we'll use two patient identifiers, name and date of birth is usually used, and then we're going to instruct the patient, tell them what we're doing, what the procedure's for, what could be some of the complications like the gagging sensation, a little bit of cough, and how we can avoid it. So the first thing we're going to do is we're going to have the patient raised to a high Fowler's position, and I'm going to have him tilt his head back for me. And I'm going to go ahead and inspect the nares, make sure there's no deviated septum, no blockage of any kind that would hinder our process of getting through to the stomach. No blockage, no deviation noted, so I'm going to go ahead and go with the patient's right nare. The first thing we're going to do is I'm going to go ahead and measure my tubing from the nose, around the ear, and to the xiphoid process. And I measured at 60, so I'm going to take a little piece of tape and mark one spot. Next, what I'm going to do is I'm going to apply a towel over the patient.
Go ahead and take a look at the site. The site actually looks very good.
I'm going to apply clean gloves.
No phlebitis. I don't see any filtration signs. So at this point, we're going to go ahead and
now that we have the tube measured, what we're going to do is we're going to go ahead and lubricate the first roughly 4 to 5 inches of the tube so that it goes down a little bit easier. We're going to have the patient tilt his head back and instruct him that he will feel a little bit of sensation in the back of his throat. We're going to go ahead and slowly move forward with the tip, the curled tip pointing down, of course.
And I'm going to...
And I'll be looking in the back of the throat with my pen light to make sure that there's no coiling going on in the back of the throat. Once I get to the back of the throat, I will have the patient sip on some water or some ice cubes and have him swallow so that he can get the tube down a little bit easier. And at this point, I'm going to have to ask him to bring his chin to the chest. And then I would continue advancing the tube until I get to the stomach. Alright, the tube is advanced all the way as far as it will go, so now it's time to test to make sure that we have the proper placement. So what I would do is I would take my 60 milliliter syringe, attach it to the end of the NG tube, and I would aspirate roughly 30 milliliters. And according to hospital policy, I would check the pH level to make sure that the gastric acid, that the content is below 4 pH, and that would signify that we are in the stomach. After I do that, the next thing I could do, I would have the patient speak. That could be another way to assess proper placement. And then I can place the stethoscope on the epigastric area and then re-administer the 30 milliliters that I just withdrew and listen for any gurgling. Okay, so gurgling was heard, so we're in the proper area where we need to be. So the next thing I'm going to do is I'm going to disconnect and hook. Go ahead and anchor. I'm going to go ahead and anchor the tube to his face, onto his nose. Now that the tube is anchored to his face, I'm going to go ahead and anchor it to his clothing using a rubber band and a pin. I would use a slip knot fashion with a rubber band and pin it to his clothing, allowing enough room for his neck to the range of movement in his head, and not to pull on the cord or the tube. And then once all that is done, I would hook him up to the suctioning device and let him be until any complications or the NG tube is discontinued. I would leave the room, and coming back for the irrigation, the first thing I would do is check placement, using the same protocol, asking the patient to speak, removing him from the suctioner device, checking the stomach acid contents, making sure it's a pH below 4, and then administering the contents I just withdrew to check and see if there were any gurgling using the stethoscope. For the irrigation, what I would do is I would take 30 milliliters of normal saline, and in the end of the NG tube, I would instill the 30 milliliters, and then I would try to aspirate as much as I could. If I got 30 milliliters in return, I know that the NG tube has been irrigated properly. If I did not get 30 milliliters in return, I would document that I did not, and then I would continue doing 30 milliliters until I was able to get 30 milliliters back. Now that I have aspirated and got my 30 milliliters back, I will withdraw my tube filled with the stomach contents that I initially instilled. I would document color, consistency, if there's any blood, how the patient is, how many attempts of how many times that I needed to instill 30 milliliters of solution, and then rehook him up back to the suction device and continue on my documentation. Thank you.